what you then do is to show what effect this has on the HSMR. And what we thought of doing after about a year of this is publishing the results. Not making any comment, just publishing the results. Let people make their own conclusions. And what you can see, now in terms of palliative care, there are actually 5 hospitals only in the country that have changed their palliative care coding enough to make more than 5 points change. The other changing palliative care haven't really been. So we know the ones that have made the changes, and we can quantify how much change it has. And we could, if we wanted to, publish it. Now, another thing which can be done is, for instance, let's say fractured neck of femur. Now, it would be possible when a patient comes in with fractured neck of femur or acute myocardial infarction or whatever. These are diagnoses of high death rate, number of deaths per diagnosis. You could actually say, well, actually, I think this was not the primary diagnosis. This might have been the secondary diagnosis. And it's conceivable that you could get a rather rapid change of patients who died, who were suddenly going with fractured neck of femur, acute myocardial infarction, or stroke, or whatever. Not from first diagnosis to secondary diagnosis. But you can quantify it. You can say, this is the change, and this is the effect on the HSMR, and then you can publish it, and people can make their own conclusion. But what you want to look for, and when a hospital has decided, okay, we've got a high death rate, high HSMR, what should we do about it? Now, typically what happens is that they sort of tidy up the coding. And then, so you might, for instance, find, quite justifiably, the case that I gave you before of atrial fibrillation. The patient comes in, dies, 67, comes in as, we have coded them as an elective admission, but in fact, the clinician says, I know that Mrs. Bloggs actually came as an emergency, you have not allowed for that fact. So it is possible to make errors in the coding. There was actually a good example was in Texas. There was a regional medical center which was the collection point for 18 other hospitals. Memphis, I think it was. Memphis, yeah. Tennessee. And patients that are transferred in have a higher mortality in general because they are being transferred to special hospitals. So we allow for that. They had not been coding that correctly because what you find actually is that teaching hospitals have a somewhat snooty attitude to coding, we found. Not just in England. In Holland particularly, for instance, I hope they don't touch me. But there are 8 academic medical centres in Holland. And they have when you looked at their coding, they've actually not really been terribly careful with coding. Now, one of the things that the report of the Mid-Staffs Inquiry Appendix 9 from these 2 Harvard professors, who incidentally are judging Massachusetts did, world experts. Actually, there are 3 there, and the third one is a joint author of our first paper in BNK. And what they said was, hospitals should be responsible for the coding that they do. They pay for it, the manager signs off if it's correct, and even though it may be wrong, they may be getting a higher death rate than they should have because it's been coded wrongly. That's their fault, if you like. It's their job to make sure it's correct. But we still allow them to change it, regardless. And so it may be that they have not, as in Tennessee, they had not been coding that. So what we have to do is to let them recode it. So one hospital in Tallahassee recoded every single one. It was the Tallahassee Hospital in Florida. And it had an HSMR of 140, published it. And they managed to more than halve their death rates from heart attack. They got into it, and reduced their HSMR like that. But they went and recoded an entire year's data, but it went from 140 to 137.5. That was not the explanation, it was still high. So what we find is that the number of expected deaths, because they have coded it so that we're totally allowing for all the expected deaths, tends to go up a little bit. And maybe the observed deaths stays the same, but then mortality reduction programs, such as North West London, care bundles, then starts going down. So what you do is to watch both the expected death and the observed deaths in the trends. And once the observed deaths starts going down, then you think, now they're really getting at it. And I think it takes a few years for a hospital to get really, but within a few years, many hospitals can go from the highest level to below the national average. But you have to watch that they're not doing anything related to creative coding, and if they are, then all you need to do is quantify it and say, you know, your palliative care went from sort of, let's say, 30, 30, 30, 30, 230. You may know what I'm talking about. This has had an effect of reducing your HSMR by, say, 5 points, whatever. And you can just quantify those things. So it is possible to deal with. You have to watch. One of the first